Assalamu alaikum everybody. I welcome you all. Our today's topic is Community Nutrition Program. A brief introduction. These are large-scale supplementary nutrition programs. Their main aim is to improve nutritional status in targeted groups and overcome specific diseases to combat the malnutrition. Now the list of community nutrition programs. Number first is Vitamin A Prophylaxis program. Second is Prophylaxis against nutritional anemia. Third is Iodine Deficiency Disorder Control program. Fourth is Special Nutrition program. Fifth is Balwadi Nutrition program. Sixth is ICDS program, which nowadays is called Integrated Child and Mother Development Scheme Services. Seventh is Midday Meal program, and eighth is Midday Meal Scheme. Now the ministry concerned about these programs. Vitamin A Prophylaxis program, Prophylaxis against nutritional anemia, and Iodine Deficiency Disorder Control program. Ministry concerned is Health and Family Welfare. Special Nutrition program, Balwadi Nutritional program. Concerned ministry is Social Welfare. ICDS scheme, the ministry concerned is Women and Child Development. Midday Meal program and Midday Meal scheme, the concerned ministry is Human Resource Development. Now the first program, which is a Vitamin A Prophylaxis program. It was initiated in 1970 and the beneficiaries were age group of 6 months to 5 years. The objective of this program is prevent blindness due to vitamin A deficiency, and it's implemented by PHC and sub-centers. Here what we give is a single massive dose of vitamin A, 2 lakh international units orally every 6 months, above 1 year. Below 1 year, vitamin A of 1 lakh of vitamin A is given, which is given usually at 9 months with measles vaccine. What is the role of vitamin A in health? To prevent respiratory infections, to maintain GIT epithelium integrity, to provide immunity and prevent nutritional blindness. Second one is Prophylaxis against nutritional anemia. This was initiated in 1970, centrally sponsored. As we know, more than 50% of pregnant women suffer from anemia, which causes low birth weight and perinatal mortality and maternal deaths. Here the beneficiaries are children aged 1 to 5 years, pregnant and nursing mothers, and the females where we use contraceptive devices and who are willing for family planning, like IUDs. This is also implemented by primary health centers and sub-centers. Now the dosage of the tablets which we give. Here we give 60 mg of iron and 0.5 mg folic acid to pregnant women, which is given for 180 days starting from the second trimester of pregnancy. And in children who are 6 months to 60 months, we give 20 mg of iron and 0.1 mg of folic acid. It is given twice a week. And in adolescent girls, we give 60 milligram of iron and 0.5 milligram of folic acid once a week. And what we also do here in prophylaxis, we go for iron fortification of salt. Now the iodine deficiency disorder control program. National Goiter Control Program was started in 1962, and in 1992 we started Iodine Deficiency Disorder Control Program. The main component of the program was to replace the entire edible salt by iodized salt, and the fortification of salt with iodine, which is 30 parts per million at the manufacturer level and 15 parts per million at consumer level. As we know, the iodine is a volatile substance, so it gets volatilized, evaporated. That is why at the manufacturer level it should be 30 parts per million, so that at consumer level it reaches to 15 parts per million. Now the main objectives of this program. Number one is assess the magnitude of problem in the country. Second, assess the impact of control measures after every 5 years. Third is to monitor the quality of iodized salt available to the consumers. And last is to conduct the IEC campaigns so that the community gets participated. Another program is Special Nutritional Program. It was started in 1970 in urban slums, tribal areas and backward rural areas. Its main aim is to improve nutritional status in children less than 6 years and pregnant and lactating mothers, and gradually being merged into ICDS, which we will discuss later on. After that is Applied Nutritional Program. This project was started in Orissa in 1963. Its main objectives were promoting production of protective foods such as vegetables and fruits, ensure their consumption by pregnant and lactating women and in children. In 1970, it extended to all the states in India and later on converted into ICDS. Another program is Balwadi Nutrition Program. This was started in 1970 by the Department of Social Welfare. The main beneficiaries were preschool children 3 to 6 years of age, and the activities here were to give additional 300 kilocalories of energy and 10 grams of protein and preschool education. Phased out because the universalization of ICDS. Now we will come to Integrated Mother and Child Development Services Scheme. It was launched on 2nd October in 1975. That is on Gandhi Jayanti birthday. It is one of the world's largest and most unique program for early childhood development and India's response to the challenges of providing preschool education on one hand and breaking the vicious cycle of malnutrition, morbidity, reduced learning capacity and mortality on the other hand. Now, why there was need for ICDS? Because routine MCH services were not reaching to target population. Second, nutritional component not covered by health services. And third, need for community participation. Objectives of this program. First is to improve the nutritional and health status of children in the age group of 0 to 6 years. Second, foundation for proper psychological, physical and social development of the child, reduce the incidence of mortality, morbidity, malnutrition and school dropout, coordination of departments to promote child development, nutrition and health education to the mother, and non-formal education to the children. These are the main objectives of ICDS. Now the beneficiaries of ICDS. These are pregnant women, lactating mothers or nursing mothers, children 0 to 6 years of age, and mothers in the age group of 15 to 45 years. What are the functionaries of ICDS? First comes District Program Officer, DPO. After that, Child Development Project Officer, CDPO. Third is Supervisor, Mukhya Sevika. Fourth is Anganwadi workers. And last one is Anganwadi helpers. They have different roles in the ICDS. Services under ICDS. Now the package of services. Package of services comes under promotive, preventive, curative, and referral services. Like first one is supplementary nutrition, second is immunization, third is health checkups, fourth is referral services, fifth is preschool non-formal education, and sixth is nutrition and health education. Here I am showing you the services and the target group. Suppose supplementary nutrition, it is given to children below 6 years of age and pregnant and lactating women. Immunization, children below 6 years of age and pregnant women. Health checkups to children below 6 years of age and pregnant and lactating women. Referral services to the children and also pregnant these lactating mothers. Preschool education to the children of 3 to 6 years of age. Nutrition and health education to women in the age group of 15 to 45 years and children 3 to 6 years, and also to the pregnant and lactating women. Now the components of ICDS. First was supplementary nutrition. What we do here is supplementary feeding and growth monitoring is done. Prophylaxis against vitamin A deficiency and control of nutritional anemia. Another is growth monitoring and nutritional surveillance, like children less than 3 years of age are weighed once a month. Children 3 to 6 years of age are weighed quarterly. And supplementary feeding for 300 days in a year. Here I am showing supplementary nutrition. Children of 6 to 72 months, we give additional 500 kilocalories and protein, 12 to 15 grams of protein. Now the children who are severely malnourished, aged between 6 to 70 months, we give 800 additional and 20 to 25 grams of protein. And pregnant and lactating women, we give 600 kilocalories and additional 18 to 20 grams of protein per day. Now the immunization. Immunization is done in both pregnant women and children. The immunization protects against tetanus and reduces the maternal and neonatal mortality. It also protects children from vaccine preventable diseases, as you all know. The immunization services are provided by the health department. Now the health checkups. For children less than 6 years, we do health checkups. Antenatal care is done. Postnatal care of nursing mothers is done. It consists of weighing, weight recording, immunization, management of malnutrition, treatment of diarrheal diseases, deworming is done, and simple medicines for common illnesses. So these comes under the health checkups. And referral services. Sick or malnourished children in the need of prompt medical attention are referred to the higher health centers. Non-formal preschool education. It is given at the Anganwadi centers. As we know, Anganwadi means a village courtyard. It's the backbone of ICDS. This non-formal preschool education is given to 3 to 6 years of children, and it also provides a natural, joyful and stimulating environment for this non-formal education. Nutrition and health education. This is a key element of the work of Anganwadi worker, and this forms a part of behavioral change communication strategy. Because this also the non-formal education is given at the Anganwadi centers, and nutrition is also given. Now the role of Anganwadi worker. First is to elicit community support. Second is wait and record each child every month. Refer the cases who need medical attention. Organize preschool activities. Provide supplementary nutrition. Provide health and nutrition education and counseling. Also make the home visits and coordinate with other staff. The role of Anganwadi helper is to cook and serve food, clean the Anganwadi premises, cleanliness of small children, and bring small children to the Anganwadi center. This is the role of Anganwadi helpers. Another program is midday meal program. It was started in 1961. It is also called a school lunch program. Objective is to improve the school attendance, improve the child nutrition, and the principle of this program is to supplement, not substitute, to home diet. That is, we give 1/3 of energy and 1/2 of protein requirement per day in addition to home diet, because it is low cost, easily prepared at schools, and what we give is locally available foods. But one thing is to here to change the menu frequently so that the students get interested. And the last one is midday meal scheme. It was started in 1995, also called National Program of Nutritional Support to Primary Education. The main objectives are universalization of primary education by increasing enrollment from class 1 to 5, and to improve nutritional status of children, and also give the 300 kilocalories of supplementation and 8 to 12 grams of protein in addition to their home diet. Thank you for watching.